Welcome to, we're having too much fun already in our conversation about cancer, specifically melanoma and the immunotherapy of melanoma in 2019. Why don't I just introduce the faces first that you're seeing? This is Ananya Malcha. She's a cancer researcher. This is Corinne Axelrod. She is a public health expert. This is Marty Rosenthal. He's a physician. Their particular roles is Marty is a patient he'll be describing, and Corinne is one of his caregivers. He's got a lot. And my name is Henry Stevenson Perez. I'm a cancer immunotherapy physician. I've been at a particular academic institution since 1977 doing cancer immunotherapy, and I'm pleased today in May of 2019 to share about some of the cool things that have happened. We have a total of about 38 slides, and we're going to try to get through them as fast as we can. And but the key part, it'll be two phases. We're going to try to get to the real nuts and bolts about what tools do physicians and patients and caregivers have available to them to play with melanoma, particularly as it gets more and more aggressive. What can you do? And how can you use these tools strategically and intelligently? This word intelligence is going to come up very soon, and it's going to get louder and louder as the evening goes forward. And we're pleased to have these representatives of researchers, caregivers, patients, and physicians, because this is something that when it's done together does really well. The more we learn to develop a vocabulary to work together, the better. Trying to think about this particular slide to get started. You're going to be hearing about at least two completely different ways to think about melanoma and its treatment today. And I'm looking at this little graphic here that sort of highlights what we mean by that. When people look at this, there's two figures. Some people might see a saxophone player, sort of a Bill Clinton sort of a guy with a nose and the saxophone and playing a note. But others might see this voluptuous lady sitting right here, and this is her nose, and this is her mouth, and this is one eye, and the others. Can you see the difference, the two things? The challenge is that you can't see both at the same time. No one can see both at the same time. And this is a metaphor for the kinds of ways of thinking about melanoma in brand new ways. We're going to close with the same slide, basically, and try to understand what this slide means. This is a battle between melanoma cells and immune system cells, and we're going to work off of that. Before we jump to the next slide, I'll just mention one other thing, and that is that our hope is that when this is over, whoever the audience is, particularly staff members and new patients and caregivers, will feel that they really understand much more about this bleeding edge field. And bleeding edge means what it says. It's just raw, and there's a lot of exciting things happening, but it can be too much. And our hope that it's going to get managed in a way that it won't be too much. I can tell you right now to get started, in a sense, I think it's fair to say that the four of us have sort of grown up together. If you live long enough, like I do, you can start to notice different phases in your life, different versions of youth. And although I've been doing immunotherapy here since 1977, with great success, we had our first patients cured with of aggressive cancer with immunotherapy alone in 1984. Dr. Rosenberg at the NIH at the same year had patients with melanoma cured as well. So then why aren't we better at this all this time? Well, it's been hard. It's been really hard. And these last 5 years have been very exciting. And the case you're going to hear about today is an example of what's happened in the last 5 years. We all met each other around that same time, and we've sort of all grown up together. And so we're going to be sharing a little bit about what that journey's been about. The disclaimers are we have no conflicts of interest, financially or otherwise, to declare. The clinical results you're going to see are just standard practice observations, things that are reported in the literature. All names are protected, save the patient who's volunteering his name. And none of the results reflect any clinical trial data that we're doing here at all. So none of the things you're going to hear about went through an IRB review for us. They didn't have to. And finally, the claims that you're going to hear only represent the speakers. And you're going to hear contradictory claims. And so they don't reflect any university physicians or government agencies. So the contents of what we're going to cover is, number one, BLUF. That's the big one I'm hearing from all of our staff. Bottom line up front. We'd like to get two motivators on the table that could really help the audience members to rapidly master this material. We want to then get into the synoptic truth about four interrelated concepts: entropy, meaning, immunity, and melanoma. How does that work? And they're going to percolate all the way through the presentation. We're going to talk about the melanoma fundamentals that everyone agrees on, and then we're going to talk about these two concepts, 4 and 5. The melanoma is so rare, so random perspective with its more is better implications, and then the very, very opposite side of the world, melanoma is common and deviously intelligent perspective, and that mantra is only better is better. And we'll be exploring what that means for staff, patients, and caregivers. The centerpiece is where Marty's going to come in is 6 altogether now. We're going to be talking about something called the abscopal effect and how you have to use lots of different treatment modalities to make that happen. And then 7 is the caregiver dimension. Korean's ideas will be huge in here. We have a case study that's really interesting and some board review questions, and our hopes to get there, and then we're going to wind up with conclusions. This is my last slide before I turn this over to Ananya. And this is the one I use to kind of get my head in the game when I hear a new lecture to decide, gosh, can I do something important now? So, and you can use this for anything. We're using it for cancer therapy. So if you stop to think about what you want to do next or what's important to do next, you'll start to realize that each one of us has external concerns that are governing our next actions, and there's internal concerns. The external concerns are presented to us in terms of urgency. The system says, you've got to do this, or the system doesn't care. Society, you might say. Internally, it's what's important to you versus what's not important to you. And when you put those together, you wind up with these 4 boxes. This one is the one that's not urgent to society and it's not important to you. Whenever you can recognize that happens, the thing to do is stop it. Cease that activity. Find a way to get that out of your life. Number 2, when you find that you're doing things that are urgent to society but not important to you, the word there is delegate. For example, taxes are important to the government but not are urgent to the government, not important to me. I delegate that to a tax preparer, okay, because it's just too much of a hassle for me. There's another category of things which are very, very important to society and, urgent to society and important to you. And the only thing you can do with those is do it. As a caregiver, you know what that means. You know, your husband just has a heart attack or your wife just has a heart attack. It's important to the 911 team, but it's important to you. You're going to have to deal with it. Here's the sweet spot. This is what we're here to talk about today. This is when you find a space of things that are really important to you and not urgent to society. The word there is plan. Cease, delegate, do, plan. And we're in a luxury space right now of doing planning. The 2 things that we hope that you're going to be able to think more positively about, more powerfully about, is this idea. Why do immunotherapists say it's not over till it's over? Immunotherapists approach cancer in a very different way than other kinds of doctors. And what does that mean? And hidden inside of the answer to this question are these 2 strategy questions. How do we make sense of cancer? How does a staff member make sense of it? It's an exploding field. It's getting worse. Hopefully you'll learn some tips today that'll help to make that easier. And if it's hard for a staff member, imagine how hard it is for a patient. The related one is how to pay for cancer. So cancer is extremely expensive. The average person who gets a diagnosis of cancer is going to be out $50,000 on average. If they have advanced cancer, they're going to be out $100,000 a year, average. Some $1 million a year. For the nation, cancer costs us now about $200 billion. We will not be able to afford it. It will be hidden in every conversation we have coming up, let's say about Medicare for All. If you're hearing Medicare for All, this will be in there. As you're listening to this, certainly as a staff member, when the reductions come, when things start changing, you really don't want to be on the wrong side of that equation when the cuts come. So this is a great time to kind of sharpen your planning skills to see how you would want to make this happen. Hopefully you'll learn things here today that'll help. And I think I might be ready for Ananya. And we're going to just jump right into the big theory.
Thank you so much, Steve, for turning it over to me. Before I get started with this very busy slide that I apologize for, I want to thank you for the introduction. And I also want to invite you, Corinne and Marty, to interrupt and comment or ask any questions or correct me if I make any mistakes, because as you said earlier, we have grown up together and we're learning a lot in the process. So again, I apologize for this super busy slide. At the same time, this is the big theory of where we need to get started. So let's start about 14 billion years ago with the Big Bang. I'm looking at box A on the top left corner. When the Big Bang explosion happened, this tiny little something that was tinier than my pinky fingernail blew up. And in that process, which is still happening right now, forces of entropy, which are things moving towards maximum randomness and lowest possible states of energy, and forces of meaning were created at the same time, which is increasing the life complexity and making the next level of life possible in our universe. So, as I said earlier, we're still in Big Bang right now, and the background image, I don't know if the audience has seen this or not. This is a picture that was taken recently of our universe, about 300,000 into the Big Bang, and it shows dark blue spots that would become empty spaces, and they're high entropy spaces, and it also shows red spots within yellow spots that would become high meaning and spaces that would support life, which sets me up for box B on the top right corner. Fast forward into 4 billion years ago, the beginning of first life, which is all successful living organisms without any kind of nervous system must be able to continuously identify the forces of entropy which are threatening their existence, such as avoid toxins, and they do that through the system called CRISPR. And they also must be able to continuously identify the forces of meaning, which for example, include food energy, finding food energy, and reproducing. And these single-cell organisms do not go malignant transformations, do not go through malignant transformations.
I just want to point out about CRISPR, the discovery of CRISPR is very recent, very, very recent, and a nice way to think about it at the audience level is that it's the immune system of a single cell. It's the way it looks at the entropic threats inside. Every organism has entropic threats outside, but also entropic threats inside. And we're going to be developing that in some, particularly when bacteria are threatened by viruses. This system has been developed to recognize when those viruses are inside and then grab them and eliminate them. Okay.
Thanks so much for adding that on. Now we can move to box number C, all pre-vertebrate organisms, and these are organisms either with or without a nervous system. They also need to be able to do the same thing that all successful single-cell organisms need to be able to do, which is identify and combat the entropic threats in their environment, such as avoiding toxins, and they do that through through a simple immune system that's made of one non-clonal cell called the immunocyte, one type of non-clonal cell called the immunocyte. And they also should be able to continuously identify the forces of meaning, again, which is things coming together to support the next level of complexity, such as finding food energy and being able to reproduce. And they do go through malignant transformation. And the last one. And
then if I can just clarify this, it's on this first thing, identifying and exporting the forces of entropy, it's at two levels that they're doing it. Just like bacteria that can avoid threats from the outside avoid toxins. Multicellular organisms have to do the same. They have to see entropic threats outside. And so they have, even if without nervous systems, they have the ability to do that. The purpose of the immunocyte is to identify the entropic threats inside. So that theme will continue as we go to box T.
Which leads us to the last kind of organisms that we're going to talk about, which are successful vertebrate multicellular organisms, such as humans. And these are all that have a very complex nervous systems. And they all also, just like prevertebrate multicellular organisms and single-cell organisms, must be able to identify and combat the forces of entropy outside them and inside them, and that's done through a complex nervous system, maybe just as complex as the nervous system outside. They also must be able to find
You said nervous system, you mean immune system?
Yes, immune system.
Okay, all right.
And they also must
So
be
in other
able
words,
to
they use a nervous system basically to identify toxins and threats outside. It's not the only way, but it's certainly one way.
Yep.
And then they use the immune system to identify and eliminate entropic threats inside.
That's right.
Okay.
They also must be able to find food energy, and they must be able to reproduce, and they also do undergo malignant transformations. So this process, as Steve was describing earlier, is called intelligence. That's what we're describing here it as. So the way life is experienced by any kind of organism is through chaos. And chaos has two kinds of forces, the entropic forces and the meaning forces that are mixed in it. Most of the times the entropic forces and the meaning forces are invisible. So any successful living organism must be able to move away from the forces of entropy and move towards the forces of meaning through successful true states detection and error correction. So the idea of intelligent motion is the ability to move the chaos towards the forces of meaning. And the reason why we have the DNA molecule there is because the mission of every living organism is to protect the integrity of the DNA, and that's done through intelligent motion. So this is what Steve was bringing up earlier in terms of the two parallel dynamics that are going on as we move closer and closer to the human level, and specifically cancer patients. This dynamic of intelligence is going on at the nervous system level, specifically the central nervous system, the brain, and the spinal cord, which is supposed to recognize the entropic threats outside and move away from the entropic threats and move towards the forces that are meaningful for it. And it's also being done on the inside, protecting the vicinity of 100 trillion cells, of about 100 trillion cells that make up the human body. And that's done by the immune system, the same thing, moving away from entropy and moving towards meaning. Next slide, please.
It's just worth highlighting that whatever you think about the complexity of the brain, of the human brain, it's been said that it's the most complex 3 pounds of matter in the universe. You have to decide whether you believe that or not. But whatever you think that could be, and however complex it is and however intelligent it could be, it must be mirrored in complexity and in intelligence by the immune system. As Anand just mentioned, it's now patrolling all of the chaos of 100 trillion cells, all interacting with each other. Crazy stuff. And then all the stuff that comes up, viruses, etc. And of course we're going to talk about cancer. And how does it make sense of that? It's able to do that very, very well. And it should not be, it can't be overstated, I don't think, about the importance that both of them are protecting exactly the same zip code. This one's protecting all the stuff inside of your skin from external threats primarily, and your immune system is doing it from internal. But why are these defining the boundaries exactly the same? They're working in cahoots is the best thing I can figure out.
So that leads me to kind of shift it back over to Steve in describing aggressive melanoma cancer cells. So what we have done is describe the fundamental ideas that we'll be using to describe the way cancer cells are able to find brand new forces of energy and export their entropy onto surrounding cells better than normal cells are able to do. So Steve will be describing these two competing theories to explain this dynamic.
Okay, so the next few, I'm going to say around 20 slides, is I'm just going to get on the table all of the options that patients and caregivers really need to know at the very beginning, because we're going to be building the case for strategy. You're going to be, for example, seeing Marty's case, brilliant response, now 5 years into therapy and still being treated. So the strategy of how you do this becomes huge, and you have to know what the toolkit is at the beginning. So let's just briefly cover what everybody agreed. There's no disagreement about these key issues. Melanoma, we think, arises from a normal cell, the melanocyte, the one that makes skin color, melanin. And somehow it goes rogue, it starts acting like cancer, and it seems to be linked to ultraviolet radiation. About 25% of melanomas arise in prior moles. People could see the mole, and then it degenerates. This is the UV connection. The person's risk of melanoma doubles if they've had more than 5 sunburns in their life. And if you use SPF 15 or higher, you can reduce the risk of melanoma by 50%. So that's the closest association there. In 2018, there were about 178,000 plus cases of melanoma, and that's up 50% from 10 years before. And about 90,000 of those cases were non-invasive, confined to the very top layers of the skin. That's a good thing, that's early stage, top. And then about an equal number were invasive, and they're penetrating into the dermis, the deeper layer. In 2018, about a little more than 9,000 people died of melanoma. It's almost twice as many men as women, and nobody knows the reason for that. We want to get that to 0. The definitive therapy for melanoma is still surgery, and no one disagrees. If you can get melanoma in a bottle, that's where you want it to be. And what we tend to do is if the penetration is 2 millimeters of thickness or more, then we tend to get these, ask for these 2 centimeter wide local excision margins. Just cut that whole area out. In addition, for any lesion that's deeper than 1 millimeter, we're recommending something called a sentinel lymph node biopsy, which just simply detects lymph nodes in the area and samples them to see if the melanoma has spread. I think everybody's heard, I think this is in elementary school, the ABCDE of melanoma. You want to see if it's symmetrical versus asymmetrical. Asymmetrical is bad. You want to see if the borders are even or smooth. Uneven borders are bad. You want to see if there's lots of colors or homogeneous color, multiple colors are bad. And you want to look at the diameter. The bigger, the worse, if it's bigger than a 1/4 inch. And then finally, evolving. Things that are changing their character very quickly. That's not a good sign. This is a complex sign. Oh, by the way, what we're going to do in the video is we'll leave these things as full screen here for you so you can find them so you can just play with them, just full screen on your own. Just stop the YouTube video and just play with it. So this is the staging system. The staging system basically starts with, if it's very, 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 very superficial, we could say stage 0. That's just wonderful if you can cut it out. And then there's a couple of different levels of stage 1 where it starts penetrating into the first millimeter of the skin. And if it has rough features to it like erosion or ulceration, if it has a lot of mitoses inside of the tumor, that adds a 1B classification. That's a worse prognosis. At level 2, we start getting past the 1 millimeter mark and penetrating deeper. And again, these adverse features at level 2 have to do with additional features of depth and erosion and mitoses. When you get to stage 3, and we have stage 3A, stage 3B, stage 3C, Now we're starting to, more than any single feature, add lymph nodes. In cancer, we use, as you know, the TNM system. All we've been describing here at level 1 and 2, stage 1 and 2, has been the tumor stage, what the tumor looks like. But now when you add N, if there's lymph node involvement, then you start to add risk. There can be micrometastases, there can be more overt metastases, and there can be monster numbers of metastases, and each one of these adds risk. Stage 3C would be the most risky. And the difference between stage 3C and the next level is when the cancer actually breaks out of either the primary site or the primary tumor or lymph nodes and starts to spread to distant organs such as the brain, the lung, the liver, intestine, etc. That's the M. T, tumor, nodes, and M. This is always stage 4. And now let's see how that translates. This is a moving target. This is a rather recent summary of all stage 1 cancers. You can see that in terms of 10 years survival, we're talking in around the 90% range for patients with stage 1 disease. If it goes to stage 2, that drops significantly. We're talking around a 60% survival. When we go to stage 3, and remember there's stage 3A, stage 3B, stage 3C, we're going deeper and deeper of risk of recurrence. And then at stage 4, it's really more helpful to start to back into the curve right over here. The 1-year survival rate for stage 4 might be in the 50% range or so. The 2-year survival range closer to 25%. So these are rather gruesome statistics. Obviously getting it early and getting it cut out is where the action's at. So we're now into the controversial part. We're going to talk about these two very, very different ways of seeing melanoma. So the dominant idea, by the way, dominant idea by brilliant people I respect completely, hardworking people, and also the one that we've inherited from the last century, is called the bad luck hypothesis of cancer. And if you're not familiar with it, just Google it, and you're going to start to see all of the literature that's been accumulated in this. What it basically says is that the normal DNA of the normal melanocyte gets progressively damaged by purely random forces like UV light. And it's going to start to alter the normal DNA of the cell, causing it to become cancer. Here's an example of this. There are just many, many, many pathways by which normal cells are in touch with other cells and responding to signals for cells like growth factors. This is the cell surface right here. The nucleus of the cell would be down here at the center, and this would be the membrane, the surface. Here's a receptor, and this is one of many signaling pathways that we see normally. The RAS2 that activates another enzyme called BRAF, that activates another enzyme called MEK, that activates another one called ERK, and then goes right to the DNA and causes it to activate proteins that keep the cell going. This is a normal pathway, and this is supposed to be here. It can be mutated. The BRAF enzyme particularly can be mutated by a number of different factors. And when it does, it transforms into something called a driver gene. It starts to cause the cell to proliferate excessively. And all of this appears to be driven by purely random external events that mutate this DNA and obviously favor the cancer cell, but that's good luck for the cancer cell and bad luck for humans, and that's the dilemma we have. This is a slide in which that shows how many people have tried to build on this genetic damaged DNA thing more. So this slide is a little tough to understand only this way. This is the top of the skin. This is the this is the skin surface. This is the outside of the patient, and then this is deeper layers into the skin. I've already shared with you that in a normal person, one of the leading events that we think can be going wrong is this BRAF mutation. We do see BRAF mutation in benign lesions that never become melanoma, but in around 50% of melanomas, it's a lesion that we see. And then we start to see these progressive layers of change where the melanocytes become tumor cells and start changing their motion patterns. For example, the dysplastic nevus has been associated with the loss of certain tumor suppressors like CDK and PTEN. These are just names of genes that are dysfunctional and can be used, the tumor cell can use to its advantage. When the tumor starts to grow radially, starts to expand in that area, there's a number of different genes that folks are looking for to see, unsuccessfully actually, to see what's controlling this. And then finally, it's going to be a vertical growth phase. The tumor is going to start to grow outwards. This is a huge feature of melanoma cells, and then maybe in our discussion later on, we should maybe focus on why this might be happening. But then it's also going to be penetrating deeper into the body. So far, there's been some linkage to a gene called MMP2, but it's not firm in any way. It's not a causative thing. It's a correlative, but not causative. And with metastases, suddenly not only do you have uncontrolled growth in the original tumor site, but now you have spread to other organs. It's that metastatic thing because we haven't found any genes that correlate with that. Why is this important? Well, your doctors are going to be talking about several drugs that we have available. For example, if the patient has a BRAF mutation, then we have drugs called BRAF inhibitors. There's many of them. The original one was called vemurafenib, but now there's many of them, the second and third generation, soon fourth. They all bind to the mutated BRAF, the active part of the enzyme, and shut it down. And they can turn these, if you have a melanoma and a mutated BRAF, they can be effective in 70% of cases or even higher. We've learned to go downstream of that, the MEK that we showed, and inhibit that as well. So there's several generations of them. Some patients, particularly if your melanoma starts on the outside of your body, not centrally on your skin, but say on your fingernail, it's called acral melanoma to the outside. There's other what are called tyrosine kinase inhibitors, or TKIs, like CKET. These are all forms of chemotherapy. They're targeted to these specific mutated genes, but they, as you'll see, operate like chemotherapy. So there's some standard chemotherapies that have been working fairly well in certain selected patients. Carboplatin and Abraxane is one that you may hear. And what we were doing for 20 years before any of this started was using a DTIC and temozolomide. I haven't given that in the last 5 years now at all. This is an example of a survival curve here in months from people who were treated with metastatic disease with just dabrafenib alone, and you could see the survival curve at 1 year versus the combination of dabrafenib and trametinib. The combination seems to work better, and those details are here. Again, we'll make the slide available so you can go by and do that, but you can also pull up this reference. So recently, based on a trial that was completed in 2017, we've actually been applying these TKIs, tyrosine kinase inhibitors, to patients that were fully resected. They didn't have metastatic disease, they just had high-risk stage 3 disease. They were no evidence of disease, but their risk of recurrence was so high that we wanted to see how they would do. This group was randomized, received dabrafenib the BRAF inhibitor and trametinib, the MEK inhibitor, for a year. And the overall result was that overall survival was prolonged to 86% at 3 years, as compared to 77% if you receive placebos. And based on that, last year, this combination was approved. It's conceivable that your physician might want to have a conversation about using TKIs, tyrosine kinase inhibitors, for the prevention of the recurrence of cancer in the adjuvant setting. So one of the ideas that gets linked to this idea, to the theory, the bad luck hypothesis of cancer, that it's rare and that it's random, is that everyone gets excited about giving more anti-cancer medicine. More is better would be the logical conclusion. And it has a lot of impact on the patient because there's lots of side effects. And this is a listing of the side effects of vemurafenib alone versus dabrafenib, the next generation, versus trametinib, the MEK, versus combination of dabrafenib. You can see how the percentages of a wide range of side effects increases as you give more of these agents and give combinations of these agents. The side effects share many of the features of some of the standard chemotherapies that we've had in the past. That is to say, while the tyrosine kinase inhibitors truly are targeted, they're designed to inhibit this gene or that gene. Obviously, there must be normal cells that have lots of the same thing, because that's what's causing the diarrhea and the fevers and other things. And there's one more thing that tyrosine kinase inhibitors share with standard chemo, and that is that the patient will invariably develop resistance to them if it's used long term. It could be within a few weeks if they respond, to a matter of months, but usually within a year, the agents, these tyrosine kinase inhibitors, become ineffective because there's something deeper inside the melanoma cell that figures out how to get resistant. And so when we offer TKI, if we possibly can, we will be doing it in a very short burst of some sort, so that wouldn't happen. So we're moving quickly, Marty, get it ready for your part, because we're moving quickly into the fifth part, which is this completely opposite idea, that melanoma is actually very common, and that it's very intelligent. It's not a random thing at all. So as Ananya covered, if you buy the explicit claim that the central nervous system protects the host from entropic threats, and is able to recognize and eliminate those threats, then the immune system is doing the parallel job of identifying internal entropic threats and recognizing and eliminating those threats. And the idea is that it could be for cancer as well. The assumption of immunotherapy is that the immune system is a non-stop entropy threat identification system, including with regard to melanoma cells. And the idea is that the emergence of cancer, including melanoma, might be very, very common. One way you could start to think about what's really going on is that the emergence of melanoma may be more related to a failure of the immune system in a spy versus spy game, rather than the emergence of the cancer cell itself. And so if you're getting a picture in your mind of a flat Earth versus the spherical Earth, it's that kind of a debate. And the more you can enjoy knowing about this debate, as you meet new caregivers and think new drugs, you should be trying to figure out for yourself which one of these things it could be. If any of you remember the Mad Magazine, Spy versus Spy, this would be the dynamic. So I deliberately chose a slide that's sort of comical to describe how the immune system looks, because it's so complex, there's no possible way you could draw it. It's as complex as the brain. It's important to note that there's a starting spot with any kind of a pathogen or an entropic threat of first responder cells of which macrophages, dendritic cells, neutrophils, NK cells are in that first responder group. And this group has been totally ignored in the melanoma immunotherapy literature. And this is a very ripe area to understand much more about. Then there's the secondary responders, and these ones are, these are non-clonal. This is one type of cell does everything. These are just one type of cell in our bodies, as best we can tell, that just do all of the work of entropy identification and elimination. In contrast, everything on this side of the line, the so-called B lymphocytes and T lymphocytes, etc., the ones that make antibody and cell-mediated immunity, these ones have clonality. They have a receptor for just one entropic threat and then respond. Alrighty, we're going to then talk about these new therapy approaches. And the most important thing to remember about this is if you're trying to now take the immune system of the cancer patient that for some reason is losing the spy versus spy game, then you're going to have to recognize that more is not necessarily going to be better. In biological systems, only better is better. It's like how much insulin you give to a diabetic. Well, it depends how many calories you're taking in, how much they're putting out, and then you give the right amount. We'll be talking a little bit about checkpoint inhibitors. We'll be talking, we won't be talking about immune stimulatory molecules, which are hot now. Oncolytic viruses are a huge growing area. There's something called taking the immune system out of the patient and rewiring it to fight melanoma and giving back. This is called tumor infiltrating lymphocyte therapy. There are cytokines that we can give signals to talk to the immune system. There's stimulation molecules you might be hearing about, imiquimod or retinoic acid, radiation therapy, cryotherapy, believe it or not, changing the gut flora of the patient can dramatically alter the immune response to cancer. And then we've been exploring vaccines for some time. Let me briefly talk about the immunotherapies that people hear about all the time. One of them is called the anti-CTLA-4 class. For example, ipilimumab is a perfect example. And the other one is the anti-PD-1 class, nivolumab, or Nivo, or Pembro. The way these work is basically this. When a antigen-presenting cell, a macrophage, finds something wrong, an entropic threat, like a cancer cell, that it can't handle on its own, then it presents it to one of these clonal cells, a T cell, that has a specific marker. This is the actual antigen, and it gets presented to the signal, and away we go. Now the ball's being passed to the T cell to start to do its part, to augment the immune response. But in addition, there are brakes that are put on the system, and one of them is called CTLA-4. We think that the purpose of this brake that's thrown on is to keep the T cell repertoire from going into autoimmune disease. What we do in immunotherapy is we provide an antibody that blocks this brake, CTLA-4, anti-CTLA-4, and then suddenly the immune system goes into high gear, hopefully liberating any T lymphocytes that know how to kill a tumor that's bearing this antigen. There's another brake in the system called PD-1, and that PD-1 is found on the T cell, and it gets progressively expressed on the T cell as it gets older and older. Any cell that bears a ligand for that can recognize that, of which some tumor cells know how to do it, but all macrophages know how to do it, they'll eventually kill this T lymphocyte. It's just old. PD-1 is also called a senescence molecule. What if we make an antibody against PD-1, covering it up? It's sort of like Botox for the T cell. So it looks young. Well, it lasts a lot longer, and hopefully the immune system will then, the immune system T cells that know how to recognize melanoma will last a lot longer. This is just to say that the response rates for people with widely metastatic disease on ipilimumab alone, that's the anti-CTLA-4, after a year, the progression-free survival is in the 20% range. And when you can combine Nivo with IPI, you can increase it north of 50. There's several regimens that are now getting into 20, into the 65, 70% range. And the most important thing is if you can get to the point where it levels off, then that may go on for a very, very, very long time. Already as an example, we're making space to do that. This is an example of a case of a person with melanoma. This is actually his head. His ear is buried in all of this. The patient's nose is right here, his neck is right here, and this melanoma is going all the way in, down his neck. It's threatening his life in many different ways. He actually got what's called a pseudoprogression response to Nivo alone, but then with some additional machinations, the immune system suddenly started to recognize the tumor. A big battle went on and shrunk it down. His ear eventually became completely normal. Checkpoint inhibitors, immune checkpoint inhibitors, sometimes you'll hear it called ICI, are also used as adjuvant therapy. Patients who have their high-risk disease and or even metastatic disease, and you get it all cut out, so they're now NED, they can receive a checkpoint inhibitor, specific anti-PD-1 Nivo, as every 2 weeks for a year, or there's a regimen where they can double it and get it every month for a year. Immunotherapy of cancer has side effects. 99.9% of those side effects all come from the same problem, autoimmunity. What we say is it's like trying to do kitchen repair with a backhoe. And so that unfortunately we take the brakes off of all of the immune system cells, and we can see autoimmune dermatitis, autoimmune hepatic dysfunction. Colitis is a big problem attacking the colon, a renal shutdown, eye problems, endocrine problems, pulmonary problems, pneumonitis of all sorts, and neurologic problems. I don't know if we'll have time to get to the case study today, but here's the general way that we handle every one of these side effects. The most important one is that the patient and the caregiver are aware what's changing as it's changed. The earlier we can find one of these, the better. If it's a low grade, so-called mild, we might just give supportive care, symptomatic care. If it becomes moderate, we almost certainly will withhold therapy for a period of time and maybe give some steroids to see if it resolves. If it's severe, they're going to probably need major steroids and many other immunosuppressive agents, and sometimes not be able to go back on this therapy. When you're thinking strategy-wise, that's a big problem. So you want to be as smart about it as you can. This intelligence is going to come up. Brady, we're into your case, and we have about 15 minutes left, or maybe a little less. Let me just briefly talk about the abscopal effect. So about 50 years ago, a group of first radiation therapists, but then surgeons and now many others, noticed something strange. And that is that you could take a patient like this patient with metastatic skin cancer, and we're looking at the PET scan of his chest. This is the airway here, these are the different ribs, this is the right diaphragm, this is the left diaphragm, left lung, right lung, and this is the heart area. It's got all of these tumors that are not supposed to be there. In this case, it was decided to take the most threatening lesions to the heart function and irradiate them. And a year later, they're all gone. By the way, this is in the middle, after 8 cycles of immunotherapy, that these just were not getting better. So they irradiated them. And what they noticed that was interesting was a year later, actually all of the lesions that were not irradiated, like these here and this one here in the liver, they disappeared as well. What happened? Well, our best theory is that this process of adding radiation therapy exposed new antigens to the immune system so that suddenly it could recognize the cancer and then fight it everywhere. That would be the theory when you get a flu shot. You don't get a flu shot all over your body. If you get it in one place, the immune system wakes up and protects the whole body, and that's called the abscopal effect. Marty, I'm wondering if this is just a good place for you to talk a little bit about your case, and you've been managing as a physician. Do you think the abscopal effect happened? And if so, why don't you just tell them a little bit about where you were at and how it happened?
Well, I think it probably did happen in my case. My case is a little different in the sense that my original tumor did not start on my skin. I was one of the 1% of melanoma patients that where it probably started on the right leaf of my omentum. So it's potentially hard to extrapolate. About 1% of melanomas don't start on the skin, they can start anywhere. And I had multiple tumors in my abdomen, left lung, and coccyx. And it was interesting after the initial treatment with ipilimumab, there was some progression of some tumors and a regression of some tumors.
A mixed response?
It was a mixed response, and that was before nivolumab was available commercially. And one of the main problem I had, even though a lot of the tumors were removed surgically from the abdomen and lung, the persistent one was in my coccyx, which had spread to the sacrum as well. So I had involvement of S4, S5, and the coccyx. Even though the 1 centimeter tumor in my coccyx had been radiated, even with ipilimumab and nivolumab, it enlarged to the size of about a baseball.
Wow.
And there was a very intrepid neurosurgeon at Walter Reed who decided that he could take this out and spent 5 hours dissecting it. And after the removal of that large mass that I had to sit on for a long time, I continued the nivolumab therapy, and I've been NED ever since.
Which has been how long now, roughly?
The original diagnosis was made in June of 2014. The last tumor, which was in the sacrum and coccyx, was removed in September of 2015. So we're coming up on almost 4 years. Almost 4 years.
What were the major side effects that you noted from just the checkpoint inhibitor therapy?
Well, I had hypophysitis as the first major side effect, and
which is the wipeout of your pituitary gland.
Right, inflammation of the pituitary, enlargement of the pituitary gland. And that was treated with high-dose steroids for a month. And that was after I had started nivolumab. I had completed ipilimumab and immediately started nivolumab therapy once it was available commercially. And the hypophysitis started approximately 4 weeks after the first dose of nivolumab. So I always thought it was probably due to the ipilimumab and not the nivolumab.
So I think this is a really important point. When you're talking to somebody who thinks that cancer is rare and random, and then they're trying to think more about more is better, it's a normal response, then they're going to be thinking about the treatment you're getting as some sort of a toxin that they're giving against the cancer, and then they're going to think that over time that you get away from that treatment, that it's going to wash out. That's the technical term, it will wash out, and then you can start again. But in immunotherapy, everything that we're learning is just the opposite. That every one of these little tweaks to the immune system to get it to wake up and to recognize the cancer and to fight it, it's a long term. We just had a patient this week who came in with an autoimmune side effect 2 years after stopping checkpoint inhibitors. Everything was fine, and then suddenly the immune system changes. So please be sure to get that language between patient and you said it perfectly, but I just wanted to highlight that. It could be, you're changing your immune system for the long haul.
Yeah, and it's not, these drugs are not the most benign drugs. I've had chronic itching for 4.5 years. I've had vitiligo, which is permanent in various areas, and it's often symmetrical. I've got a little bit of soreness in both my thumbs, which hasn't really stopped me from doing things. So it's you know, it's important, I think, to recognize the side effects early, treat the major ones, live with the rest, and you just go on with your life. And, you know, I think it's really important to try and live as normal a life as you can.
Well, I would say that you and Corinne have anything but a normal life. They travel all over the world and do amazing things, and this is just, they're poster children for everything that we want. Before we switch to Corinne, because as we move to the end here, what do you, how are you seeing this long term? You're now setting new indoor records for receiving EVO. How do you decide what to do? How do you think this, you could get it for the next 10 years, or how are you playing it out?
Well, I think theoretically, I think it's going to be a lifelong treatment course. I just had my 78th dose of nivolumab today, and I've been on immunotherapy now for 4.5 years. I don't envision going off immunotherapy. We're considering gradually cutting down the frequency of the dosing. The dosing will probably stay the same at 240 milligrams of nivolumab per dose. But I don't think I would be cutting it back any more than every 4 weeks. Currently, I've been on every 3 weeks for about a year without any recurrence. So,
that being said, there's no two patients in our, we have a large service, melanoma service, no two have the same. They go on vacation, say, all right, we'll move it up a little bit, move it back a little bit. Somebody goes off for steroids for a long time, and then they come back. There's no two patients are getting the same regimen. Do you mind if we summarize here, because I want to make time for Corinne. Let me just briefly share with you. We'll leave this slide up for you folks. You know, I would just say what Marty is a patient pioneer. They really are setting, we're all learning from them and with them. Pioneer is not fun. It's only glamorous in hindsight. The kinds of things that I think that Marty and patients like him help us to learn is, number one, what are these brand new scientific concepts? For example, bad luck hypothesis versus SPY versus SPY. What are the treatment approaches? TKI versus ICI. What are the multidisciplinary approaches? Are you using a palliative approach to treating? If you're using first line, second line, third line sort of thinking, that's going to be palliative. But not in immunotherapy. In immunotherapy, you can launch the abscopal effect within, I don't know, a few days at the end. It's not over till it's over. And if you can get it to turn on, then it turns on and everybody is fine. So you have to be aware of that difference. There's new risks of autoimmunity, for example. And as Marty was saying, your immunologic identity changes over time, and then the costs. Everyone is a unique scientific experiment in this way of thinking. How important is it to actively understand and grow scientific approaches as a collaborative partner? We try to make every one of our patients a collaborator in their own experiment. I just put this in for the fun of it, but I think the fact is I try to make it very clear we're all here just for a short time. And this adventure, this cancer immunotherapy adventure, as painful as on one as it can be, is an excellent way to give thanks for life. I certainly feel that every time I see you guys, and every time I see the amazing things that you guys do together. With that, caregiver power is huge. Do you mind if we just directly, you don't have to answer any of these questions, Corinne, directly, but what advice would you give to any caregiver? They hear about melanoma for the first time. How do they process it?
Well, for us, getting the melanoma diagnosis was kind of like our personal 9/11, that one day we were fine, we were normal, and then boom, all of a sudden our whole world has changed. And just like we really didn't know all the forces before 9/11 actually occurred that were happening, same thing, we didn't know what was going on in Marty's body. We thought, we were, we had our little, little aches and pains, but so it was quite a shock. And because his was so unusual, it took a while to actually figure out what kind of cancer it was. So we had a period of about 2 weeks where we kind of just sat with the information. We didn't tell anybody. We kind of were digesting it, and perhaps because we didn't know what it was and we really didn't have information to tell people, in hindsight that was kind of a blessing that we could sort of just absorb it and because it's quite a shock. And what we then did was that we thought about who we should tell, how much we should tell, and we talked a lot about that, and then we just decided to tell everybody everything, to just completely open ourselves up. And we started a Caring Bridge site, we kept people informed, and it was therapeutic for us, and it was also, I think, helpful for a lot of other people. We had people that told us that they themselves have gone through similar situations and didn't tell anybody, and they really regret that. We had just such an outpouring of support from family and friends, and people that had little, issues before. This was like a silver lining, and that people realized how stupid, some of their little issues may have been, and, realized what's important in life. And so for us, we felt extremely lucky that we had such a incredible support system, and we also realized that we had to let people deal with this in their own way. So some people deal with this by, and when I say this, hearing that somebody they know and care about has a very deadly diagnosis. Some people deal with that by cooking, some people by sending us things, and other people we didn't hear from for 2 months, and we thought, well, that's really odd. But then we found out it's because they were so affected by it that it took them that amount of time. And so we learned as well to give people the space that they needed.
If I can just sparkle a couple of things you
Yes.
said. You by opening up, and you guys have opened up in an amazing way, I'm hearing you say that it's worked out well for you. I do want to just thank you for all the other lives that you've touched through your generosity. Every time I ask Marty, it's hard to think in the beginning of cancer, of melanoma strategy, how am I going to do this 5 years from now, particularly when the numbers look so rough. But he's been very generous, and you have too, and I want to thank you so much for that.
Well, we've been very lucky. We've had just a wonderful team of people working with us, and the other thing that we have learned is that there is no one answer, and that there's many decisions along the way. Should he have surgery? Should he have surgery on this? Should he have radiation? Should he have this? Should he wait?
How do you, I mean, he's obviously the decision maker, he's obviously my patient, but you've been huge. How do you fold into that?
I think it's been helpful that we can talk about that, and that the clinical staff here has been so wonderful and so honest with us. I know not everybody is so lucky in this regard, but every single doctor that we have worked with here has really taken the time to talk through with us the options, to really listen to us and see what works for us. So I think, we try to get as much information as we can, and then we also then ask the doctors, well, if this was you, what would you do?
And what I say is, we're in the high branches, I have no idea. You're a doctor, what do you think you should do? And that's how we got to 4.5 years in Eagle.
Yes, and we're all guinea pigs in life, and so there is no one answer. I mean, there may be some diseases where, yes, this is what you take for how long, and that's it. Cancer is not like that. It's very unique, and the treatment is unique. So what works for us may not work for everybody else.
Let me jump to the last question, because this also amazes me about the two of you. You position yourself so brilliantly to be available to the community. You have lots of community service you do, etc. And you travel and do wonderful things. I remember one day when it seemed like both of you were on crutches. You were doing something for HIP, etc. How do you take care of yourself when all this other stuff is happening?
Well, it's a really important thing for the caregiver and partner to take care of themselves, and it's a hard thing to do. And I can't remember if it was, I had a knee replacement and a hip replacement, and I can't remember when I had which one, but people would say to me, well, why are you having that done now? Why don't you wait for a better time? And I'm thinking, well, exactly when might that be?
What would that be?
Who knows if there'll be a better time or not. And thankfully for us, things have worked out great, but you have to take care of yourself as well. people would say to me, you know, oh, you're coping so well, and I'm like, really? Because I'm really terrified. And I'm glad it looks like that to you, but you know, it's really a very scary thing.
I know it's hard, and you guys as pioneers on this, again, are being very generous in helping other people to sort of process it. We are running out of time, and so what I'm going to do logistically is, number one, we will be posting this case study. So it's about checkpoint inhibitor rashes, a very, very common problem, and how to identify them. I'm going to go through these slides, but I'm also going to, we're just going to post them in the video so you can stop it and read it and watch it yourself. How to do the diagnostic workup, how to get referrals. You're going, if you're managing your case, you're going to be meeting more subspecialists with these autoimmune side effects and learning to learn collaboratively with them. In many cases, they may have never seen this before, and so you're going to have to kind of help them through. We're on the last slide. I'm going to try to summarize this as quickly as I can. And that is, why do we say it's not over till it's over? Well, in immunotherapy, the idea is that if this battle zone, this is melanoma, this is immune system T cells and associated macrophages that are now turning the tide. The macrophages, this is the that gentleman that you saw that had the huge ear thing that was invading inside of his head and down into his chest. These cells had their way, they were going crazy, and now we help the immune system cells to win the battle against the tumor cells, to be more, we say, more intelligent, to recognize that they're there, and then to do something about it, to recruit all of the support that's needed to kill these cells. This gentleman went into complete remission in a battle zone like this, and every patient who's having remission has something like that. It may not be the same, which brings up a related one. If you take something like UV light, yeah, UV light sounds very destructive to me, and I can imagine where UV light as a random entropic event could cause BRAF mutation and many other mutations. But how do entropic events, things that destroy, make a tumor cell more intelligent, a normal cell be able to outcompete the other cells for energy and to export entropy? This is straining the imagination. Why don't we have any research, for example, about the effects of UV light on the immune system cells in an area? It's more likely the immune system is being wiped out in that area, and that's what's giving the advantage in the SPY versus SPY. Obviously, these two things are, it's like this flat Earth versus spherical Earth. There will be an answer coming soon, and hopefully as the participants are watching, they can see that this conversation that we're having here between patients that really get into their own care, caregivers that get into the conversation, and physician working collaboratively. I hope, if there's no other proof, the idea that our patients themselves are very intelligent, our guiding conversations is very helpful. I'm going to echo this cute little thing to say there's more than two ways to think about this, and we're in the middle of that conversation. I am tuning out. Thanks so much. Oh, just one last thing. If you like the video, please, or even if you dislike it, put in comments, because we're going to learn, we're going to continue the conversation offline, and hopefully we'll be posting some more soon. Thanks to you guys so much.